Okay.
All right, it's 7:30, so let's get started. Good morning, everybody, and welcome to UT Health San Antonio Pediatric Grand Rounds. As a reminder, as you log on, please mute your devices. Also, the Grand Rounds attendance code will be placed in the chat periodically, so you can just check there for attendance. Otherwise, it is my absolute great pleasure to introduce our speaker for today, Dr. Alice Gong, who actually needs no introduction whatsoever, but we're going to do it anyway. Dr. Gong obtained her medical degree from the University of Mississippi School of Medicine and then pediatrics residency initially at UTMB Galveston. She then shuffled off to Buffalo with her new husband to finish her pediatric residency at SUNY Buffalo. Dr. Gong then joined the UT Health San Antonio faculty in 1985 after completing her neonatal perinatal fellowship at SUNY Buffalo. And she's been here and has risen through the ranks to professor and beyond, while she, with her bare hands, helped build this department to what it is today. Her passions in neonatology include nutritional support of premature infants to include breastfeeding, respiratory distress syndrome and surfactant replacement, retinopathy of prematurity, and follow-through care of NICU survivors. Her most recent work has been in improving family support of NICU babies to improve their outcomes. She has served on the Texas Newborn Screening Advisory Committee since its establishment in 2010. She's currently part-time and plans to retire next year. We'll see about that. And she's most proud of her 3 children and 4 grandchildren. So, Dr. Gong, you have the floor.
Thank you, Dr. Ranch. To minimize this thing so you won't have to see it. Okay. Thank you very much for this invitation. And newborn screening has also been one of my passions, and there's been a lot of changes in newborn screening. So I hope we all learn something from this. I'm trying to advance my slide, and it's not working. Oh, there you go. So what I'm gonna do, if I can get rid of this thing, which doesn't want to go away. Are you seeing this on your screen too? Anybody?
Dr. Gong, we see your slides perfectly. So
Oh, you do. You don't have
we
this
don't
thing
have the
that
extra
I
notes or
can't
anything.
get
Yeah.
rid of. Okay, so I want to go over the purpose and principles of newborn screening program because it is a cornerstone to pediatrics. Summarize national policies that involve newborn screening, and then characterize the uniqueness of newborn screening program in Texas, and hopefully you can kind of recognize some of the conditions because there are a lot of conditions. I'm going to go through it somewhat cursory because each one of the conditions warrants its own individual grand rounds. Okay, so what is newborn screening? It is the practice of testing all newborns in the US, and it is all newborns in the first days of life for certain disorders and conditions that may either keep them from living or hinder normal development. And it is required in every state and US territory in their public health system, and it should be performed before the baby either leaves the hospital or the birthing center. The conditions in the newborn screening typically are those that have no symptoms at birth, so the baby looks perfectly normal, but can cause significant morbidity or mortality if not detected and treated early or quickly. This is one of the tenets of newborn screening, that you need to have something that you can recognize before there is symptoms and that you can treat and prevent damage. And it has been named one of the most successful public health interventions in the 21st century, mostly because a lot of what we do now in the 21st century was not done in the 20th century, although newborn screening started then. Okay, so some facts. There are about 4 million births in the US. So about 1 in 178 are found to have some kind of devastating condition through newborn screening. And in Texas, newborn screening started in 1963 with the Guthrie test, and that's how we got to filter paper. So all the states, uh, District of Columbia, Puerto Rico, screen now for 31 of the 38 recommended disorders. And I'll go over how you get to recommended. So annually, about 20,000 newborns in the US benefit from this early detection and life-saving treatments. Most babies with serious but treatable conditions discovered by newborn screening actually grow up healthy with expected development. So, in terms of the federal government, the first law was passed in 2008, but prior to that, it was actually recognized that states were doing things differently. And so it actually was one congressman who found out that his sister, who had a baby in another state, got more testing than his baby did, which started a task force and studies. And so a law was passed called the Newborn Screening Saves Life Act that says there is going to be a national newborn screening guidelines to support states so that they can get more uniform screening. And prior to the passing of that law, there were only about 10 states that were doing most of the recommended screenings that had been set up by the genetics group. And then after the law passed, we have now gotten to almost all the states. That law um, lasted until 2014, and it was reauthorized. And when it was reauthorized, there were things in there that improved and expanded state newborn programs, addressed the need for education, and then having some federal policy for protection, and then set up standards and surveillance efforts. That was to expire in 2019. In 2019, the House passed it, but the Senate did not address it. And so it kind of been waiting for the Senate to approve it, but it did not. So in 2021, the House reauthorized again, giving until 2026 for the Senate to pass it, and it did not. Okay, so what the authorization would have done was that there would have been HRSA grants to help states expand and improve their programs, provide education for parents and healthcare providers, and improve follow-up care. And also allow for the CDC to do prevention newborn screening quality assurance programs to make sure that testing is accurate. It started a program called Hunter Kelly, a newborn screening program that will fund research so they can identify new treatments and develop new screening technologies. It set up the Advisory Committee on Heritable Disorders in Newborns and Children. So this is the act, which is very difficult to say, but that's the committee that goes through the process of looking at conditions through a lot of vetting that includes not only the experts that are doing the studies, but also populations affected, so parents of children that may have had that disease, as well as other stakeholders. And they are the ones that can allow new testing to go to the recommended uniform screening panel or the RUSP. And they also would have allowed for the National Academy of Science to develop policy recommendation on how to modernize the system as new equipment and technology becomes available. So that act did expire. And so in 2014, and what happened was that the Advisory Committee on Heritable Disorders in Newborns became a discretional committee under the Health and Human Services to continue to provide that function. And unfortunately, this committee was disbanded in April of this year. So although there's federal legislation, actually who is responsible for newborn screening is the individual states. And so Texas has two policy statements, and they're in different places, unfortunately. So, Health and Safety Code, Chapter 33, actually covers all of the newborn screening that is done by the lab. Legislation has been passed that the lab can add new conditions that are under us as funding allows. And CCHD screening, which is critical congenital heart disease screening, was added to that area. The hearing screening actually went under a different law in Chapter 36, and that's something that is going to be there and we can't change it. Okay, so what is the recommended uniform screening panel? It was established to standardize the list of disorders that are supported by the Advisory Committee on Heritable Disorders in Newborns and Children. They recommend that a condition be added to the Secretary of Health and Human Services, who then signs off, and then it becomes part of the RUS. So the RUS is still there. But what happened is that states, but remember, the states decide for themselves what conditions to add. And as of today, the Texas Newborn Panel has all the conditions with the exception of guanidinoacetate acetate methyltransferase deficiency, or GAMP, which I'm going to refer to because it's a lot easier to say. That implementation is planned for either December or early spring of 2026. So some history about newborn screening. So as I've mentioned before, in 1963, Texas started PKU screening. That is why a lot of people still refer to newborn screening as PKU, although PKU is only one of many conditions that is funded. So for 35 years, Texas funded newborn screening. A fee was not instituted until 1998.
That's okay.
When about that time around the country, there was developed tandem mass spectrometry, which can then, I think someone's got there's okay. So what happened was Texas was still screening for the same 5 conditions. And so through some advocacy work with Texas Pediatric Society and Texas Medical Association, a task force was formed to look into expansion of newborn screening. That task force reviewed the literature and recommended expansion. And actually, it was not until, and then asked for legislation. So House Bill 790 in 2005 actually expanded screening, stating that tandem mass spectrometry is what is needed. So that's what happened. With that law also came about the Newborn Screening Advisory Committee. Okay, so what is unique about Texas? In addition to expanding screening, it became apparent that all the blood spots that have been around since 1963 were being kept. And there were ways that you could do testing if you go through the IRB at the health and as the state health department. People got upset about that because the government had their kids' DNA. Therefore, there was a lawsuit filed against the newborn screening of program. In order to avert the lawsuit, this program made recommendations to the state legislature. So House Bill 411 in 2011 actually addressed the issue of the blood spots. So basically, if parents consent, the specimens can actually be stored up to 25 years and can be used for external research if it passes the IRB and it meets the approved requirements that are stated in the legislature. If the parents don't give consent, specimens are stored up to 2 years, not used for external research, but maybe to use some for quality measures to kind of make sure things are that they meet the standards. So because of that law, new forms were made, collection kits would change. So storage of the newborn blood spots is an opt-in process, and parents have to approve it. So what happens with the kids that come out is this form where parents, this should be given to the mother when they're doing the first newborn screen, and they can check yes or no. Or okay means the blood spot will be kept. No means I don't want the blood spot kept. It will be destroyed after 2 years. They can give that back to the staff, and that can be sent to the state, or they can mail it in. Because Texas does two screens. If the first one says yes, but the second one says no, it will not be kept. If the first one said no, but the second one says okay, it will be kept. So those are the conditions. Um, so now newborn screening itself is an opt-out. In other words, it is state mandated. And the only way, according to statute, that you can refuse newborn screening is if you have a religious objection. So and there is a form that can be found on this link to get to the that form. So the process that is recommended to pediatricians and people who attend the birth of the baby who are responsible that newborn screening be done is that if a parent does not want newborn screening, you need to be able to discuss the general purpose and benefits of newborn screening, answer questions, provide some printed information, which I'll show you on the next slide, and then explain that the only legal reason to refuse is if the test conflicts with their religious practice of an organized church of which they're members. That is written in statute. And then show a video which talks about how wonderful newborn screening is. These are some of the things that you can find online that you can print and share with families. So there is a form, and you should download it if you have a parent that says, no, I do not want this done. And basically, you fill out the form, and they have to check that I have heard the benefits. I know I can only refuse this because it's against my religion. I don't want my baby's tested, and you're supposed to give them that copy because they're supposed to show that to their baby's doctor so the doctor will know the baby did not get a newborn screen. And then the bottom part is supposed to be filled out by the facility and sent to DSHS. I don't think the system works that well because we don't get very many of these. Okay, so what does Texas do? We screen for 59 blood disorders. It will be 60 as soon as GAMP is added. And then there's 2 point of care. One is hearing and one is critical congenital heart defects. The blood spot tests are done on filter paper. The first one at 24 to 48 hours of life. This is true for every baby. So even the NICU babies get it within 24 to 48 hours. If a NICU baby was transfused before that, there's a caveat to send it, and then to remember to send another one after you've passed 3 months from the last transfusion. 7 to 14 days, again, same for NICU babies. And the reason we do this is because it maximizes detection. And actually, a good portion of the congenital hypothyroidism is found on the second screen. Texas is one of 10 states that do a second screen. And there was a comparison between states that do first screens and second screens, and the states that do second screens continue to find conditions beyond the first screen. The cost of the kit right now is $60.63. Due to the fact that we're adding a lot of new conditions, the test will go up to $94.81. There are 2 different forms. There's a Medicaid CHIP and charity form, and then there's an insurance and self-pay form. The Medicaid CHIP charity forms are provided free, and the insurance self-pay the kits have to be paid for. Okay, I'm going to go through all the disorders in a very cursory order. First is the amino acid disorders. This is where an enzyme is not there or not enough there, and so it causes buildup of abnormal amino acids. The classic is your PKU. That is, all of the conditions here are done under the tandem mass spectrometry. The red ones are those that are core condition. Texas also screens for the secondary conditions that are in black, and that's going to be the key to the conditions. So amino acid disorders. The next one is fatty acid oxidation disorders. These are disorders where enzymes are not there to break down fatty acids and therefore can cause problems. The major one that you may know about is MCAT, which is very important to pick up early because when babies are not fed regularly and they don't have fuel, they can't generate energy, and that's one of the reasons why they get into a lot of trouble early on. Organic acid conditions are those where enzymes don't break up certain amino acids, organic acids, and there are non-core conditions. Actually, our NICU actually had a case of MMA recently. Okay, so endocrine disorders, I don't have to kind of go over those because usually we all know about congenital adrenal hyperplasia as well as primary congenital hypothyroidism. These are the two conditions that are more frequently picked up on the second screen. And in the hemoglobin disorders, in addition to the beta thal, SC disease, and sickle cell anemia, the state also does screening for all the hemoglobinopathies. Lysosomal storage disease just got added in August, and I'm going to go through each one of these, but there are Pompe, MPS 1 and 2, and infantile Krabbe disease. Other disorders, of which I'm going to go through some of them, are X-linked adrenal leukodystrophy, biotinidase deficiency, classic galactosemia, cystic fibrosis, and SCID, as well as SMA. In addition, because you're screening for SCID, you get the T-cell related lymphocyte deficiencies, which is not a core condition. And then we have 2 point of care, which is hearing loss and critical congenital heart disease. Okay, so kind of cursory, but I think these are the conditions that you need to know what the state does. So as you all know, cystic fibrosis is an autosomal multi-system disease that affects quite a few U.S. newborns. It's caused by genetic mutations involving the cystic fibrosis transmembrane regulator protein. And because of that, you end up with all the different issues that we see systemically. What Texas does is it looks at immunoreactive trypsinogen, which is the IRT. If the IRT is abnormal in the first and the second screen, then a DNA approach is used, and Texas screens for 46 of the mutations, picking out those that are more common in the Hispanic population. Obviously, there are more than those gene mutations that can cause cystic fibrosis. So unless you have that DNA positive for the gene, if they have abnormal IRTs, sweat chloride is still the gold standard. And it's very nice because the CF centers in the state actually do a lot to help with the follow through on this test particularly. So what happens when you don't get a second screen and on a baby? So CF was what required the state to try to connect the two screens, which is somewhat difficult because names change, providers change, so many things change between the first and second screen. But they're actually able to do that about 80 to 90% of the time, connect the two. So if you get a first screen and the IRT is abnormal, but you didn't get a second screen, they will go ahead and do a DNA approach, do the DNA testing. If you only get a second screen, they would still go ahead and do DNA. And there are times when we have reason to suspect because of in utero situations, we can actually call the state and tell them to just go to DNA. That's cystic fibrosis. Severe combined immunodeficiency screening is quite neat. What it does is it does a PCR looking for something called TREX. Tracks are actually formed when lymphocytes are being formed, and what they're doing is that the DNA is has to get rid of this piece of material it doesn't need. When it happens, those little circles are called tracks, and there's a surrogate marker for what the thymic activity has been recently. So if it's low on both screens, so sometimes we get a low one on first screen. If there's nothing that makes you think there's something wrong, you can wait for the second screen. And when that happens, then the tests are done. The baby needs flow cytometry, looking at T cells and B cells and NK cells, so you can figure out the subtypes. And then there's genetic testing to confirm whatever mutations. So if you have abnormal first and second screen, you need to refer to a clinical immunologist. SCID is that condition that prevents with infections very early in life, and other autoimmune issues like rashes and liver dysfunction, hepatosplenomegaly, and diarrhea. Very difficult to diagnose in the past. It is more common in males because if it's an IL-2 receptor gamma chain deficiency, that is X-linked. It can detect syndromic immunodeficiencies like the George syndrome, DNA repair disorders, metabolic disorders, and even extreme premature babies whose thymus may not be working so well, any severe congenital infections or some other malformations. So it is a broad screen, but it can be narrowed down. The treatment is getting a stem cell transplant to reconstitute the immune system with normal immune cells. And the outcome is amazing if you can do it before you ever have infection. Um, Okay, so XALD is where the very long chain fatty acids, which is your carbon 24 and 26, cannot be broken down. So you get this buildup of VLCFA, and that disrupts myelin, causes nerve conduction issues, affects the nervous system and the adrenal glands. It is, again, more common in males, although some women carriers do have symptoms in adulthood. So what the screen does is that we pick up um, the C2426, and therefore you need to get very long chain fatty acid levels as well as your ABCD1 gene, because that is a common gene that causes XALD. There are three forms, and we can't tell you which form, but the state can tell you that if you don't have the childhood cerebral, which is the very early onset, you may develop adrenomyeloneuropathy and Addison's disease. So the positive cases are followed by neurologists. And there have been a number picked up. Zellweger's is one of the conditions that can present with abnormal screen. SMA is autosomal recessive and is degeneration of alpha motor neurons in the spinal cord. And so that leads to muscular atrophy. These kids are not typically seen in the newborn period. It is relatively common. 1 in 50 Americans carry the gene. So what happens is that you can have mutations of your survival motor neuron 1 on exon 7. That produces the SMN protein that is needed for the nerves to control muscles. If you don't get if your SMN1 doesn't work, you have an SMN2, which is your backup gene. And the more copy numbers you have, the less severe your disease is. So the screen identifies the SMN1 deletion and also looks at the number of SMN2 copy numbers that you have. And if you have 2 or 3 copies of the SMN2 only, then you do qualify to get the therapy that is available. So remember, there are 4 types of SMA, with type 1 being the most severe. That's your Wernicke-Hoffman. These kids are typically present pretty early with muscle weakness, trouble breathing, swallowing, and coughing. I don't know if the therapies actually work for type 1. Type 2 is where things are delayed, so baby looks good, but then starts having delayed milestones or not developing any milestones. These kids typically can maybe could sit up but cannot walk. Type 3 is cougar bird Wieslander, presents a little bit later. This is the juvenile form. These kids can walk, but they have mobility issues. And then type 4 is the type that presents in adulthood with mild motor impairment. And actually, in less than a year after implementation of SM1 SMA screening, the state identified 16 cases. So treatment is available. What was first available was nusinersen, which is um, what it does is it increases the ability of the SMA protein to last longer. It is given through a spinal tap. It is quite expensive and has to be repeated. So Gensma or Ana anyway, it's the first gene therapy that's available for children. It uses an adenovirus vector to deliver a fully functional copy of the SMN gene into the target motor neuron cells. It is given as a one-time IV thing. It is quite expensive, but it is FDA approved. And then finally, there is an oral drug that is available that is an SMN2 directed RNA splicer modifier. Uh, with an open label trial, they were able to have some improvements. For late onset, the primary endpoint was that they have increase in this MFM32, and they were able to achieve that. So it is quite expensive based on the patient's weight and has to be given more than once. Okay. So on to the new glycogen storage diseases the lysosomal storage diseases. These are conditions where you're missing something in your lysosomes. Therefore, you can't get rid of things that you should be able to get rid of. Pompe was the first lysosomal storage disease that made it to the refs. This happened in 2015, but because of the need for special equipment to do lysosomal storage disorders, it took the state quite a while. And so all the lysosomal storage disorders came on board now. So this one is absent alpha glucosidase or GAA. There are three forms: the infantile form, which presents with myopathy, hypotonia, and failure to thrive, poor feeding, respiratory distress, etc. There is the non-classic infantile onset, which is age delay until age 1, when you start getting delayed motor development, weakness, respiratory distress. And then there's the late onset where you develop progressive weakness. There is enzyme replacement therapy to increase the GAA, and it's very important when we diagnose this to get this going. Okay. The next one is, sorry, I have something in my way. Okay, it's MPS 1, which is missing the alpha L iuronidase or the IUDA. It is a progressive multisystem disorder. While using tandem spectrometry, we can detect the low IUDA enzyme activity, and then to diagnose it, you have to measure activities in either the leukocytes or skin fibroblasts. You cannot predict the phenotype, and there are many genetic issues, but you can get a stem cell transplant to help so that you can produce the endogenous enzyme, or you can get enzyme replacement, although enzyme replacement for MPS 1 does not cross the blood-brain barrier. So Hunter syndrome or MPS 2 is X-linked. It is missing glycosaminoglycan. And so to diagnose it, you want to find that this enzyme is deficient in white cells, the fibroblasts, or plasma. There's an early progressive form, which gives you pretty bad things where you're more likely to die in the first and second decade. There's a slower progressive form, These kids actually have distinctive features, and there is enzyme replacement therapy, and getting stem cell transplant can uh, uh, help in this condition. The last is the one that is more important, that we diagnose early, because we're only looking at infantile onset Krabbe disease. This condition affects the myelin, so you get a rapid decline in the nervous system. It is the galactolipids that build up. Um, so basically, the screen is cytosine levels, and you may get a report that it's borderline or abnormal. If it's abnormal, you should be able to get results within 4 days of the sample. And the reason is that these kids need to get into stem cell transplant within 30 days of life. So it's very important that we pick these up. Expected 1 to 2 cases in Texas. We have 3 places in Texas that will serve as the Krabbe Referral Center. And notice that Dr. Odom at Christus Health in San Antonio is one of the sites. Okay, last kid to come to the plate will be GAMP. It is very rare. There's about 110 cases worldwide. It is due to mutation in the gene, and that is essential to create creatine. So when you don't have enough creatine, you have higher of the guanino acetate, which leads to serious brain and muscle symptoms. So there are a lot of cognitive impairment, language, behavior problem, seizures, poor muscle tone, poor muscle skills. If the symptoms don't develop until after the maternal creatine is used up, so around 3 months, and early diagnosis is very important. Treatment is actually giving creatine and getting a diet low in arginine. Okay, so Texas does have a couple of tests that are not in the RUS. Unfortunately, the CMV legislation passed in 2023 when we still had the RUS. So thinking that RUS will pick up CMV, because during that time, the way to detect CMV, the best way is through saliva, but there are tests now that can pick up CMV in the blood spots. Not as effective as saliva, but it would be a good way to pick up congenital CMV, knowing that a lot of congenital CMV presents with hearing issues. That legislation says that if a baby doesn't pass the initial hearing screen in the hospital, they need to have their CMV tested. They did recognize that not all places can produce or perform a congenital CMV test, which is a saliva test, but they said that you need to refer. Now, there's no enforcement. This is just what the law says. And sorry, you got to go back up. Okay, and so basically, there's no tracking. It's just we have a law. Okay, Duchenne muscular dystrophy, which was another condition that the West was considering before everything got disbanded. We did get a law, SB 1044. There's a lot of families pushing for this. The law does say that implementation is not until new lab space is built, which is not slated to happen until 2026, 27. They will need new equipment, and that equipment cannot be funded except through legislation. So the families that are very pushing for this are already gearing up to get legislatures to provide funding at the next legislative session. Okay, so lots of new conditions, and I know you won't remember them all, but hope you remember some of them. Newborn screening is a system. It has to be. The baby is at the center, but many, many different things are affected by it. And just remember that it takes a big village to make it all work and to make it work as well as it does. And in Texas, we have a very robust newborn screening system. Okay, so how is it done? The blood spot, the filter paper. It's very interesting. They just did a survey of providers in the state, and only 60% knew that the first blood spot was done at 24 to 48 hours. So, uh, so uh, if you go home before 24 hours, you just do it as soon as you can. I mean, as late as you can before the discharge. And the second one is 7 to 14 days. The sample is by legislation to be collected by the healthcare provider or designee. So if you're in a hospital, you can designate the lab to do it. Um, Texas, we went through when we were going through like back in the trying to figure out legislation, looked at a lot of laboratories and to see if they would just use one laboratory. And in fact, the state lab in Texas is the largest lab that does newborn screening in the world. And that's because California, that has more births than Texas, has 5 different labs as opposed to one. So we have one centralized lab that does all the testing. Lots of positive benefits and some issues there. Hearing is to be done 24 hours uh, or before discharge. And that is because in that first 24 hours, there's still gunk in the ears, and so it's a little harder. There are 2 different tests that are acceptable, OAE or otoacoustic emissions or auditory brainstem response. I'll go through those. Hearing, what you want is to screen babies by 1 month. So those babies that are born in areas like birthing centers that don't have screening technology, they need to refer those babies to someplace that could do that. Diagnosis in that is by pediatric audiologists by 3 months and intervention by 6 months. And that is getting them into hearing places where they can get hearings aids, etc. Critical congenital heart disease is again 24 hours or before discharge, and that's because you want the ductus to close. It is done by pulse oximetry, looking at pre and post ductal SATs. Okay, so this is a report card for Texas newborn screening. This is for the year 2023, and the reason is 2023 is because it takes time to gather all this data. And you know that there were 33,900, 392,000, etc. screens. That is probably the birth, around the numbers of birth. There's probably some missing there. We do not know if every baby in the state of Texas is screened because it is not tied to birth certificates. There's a project that's being worked on, so we will know if every baby is screened. If you double that number, it's going to be about 25,000 more than the total number of specimens received, and that's because there's drop off between the first and second screen. There's a lot of things about when they collect and so forth. The unsat rate is 0.9%, which is not that great, and that's something the state is working on. But this is their report card, and there are a lot of room for improvement. Okay, so of those, there were quite a number of presumed positives, about 18,000, which is true, but then there were about 2,000 critical ones. And thus far, there's about 1,151 diagnosed cases, and that's because there's still a few cases that are still being worked out. But that's typically what we see, about 1,000 diagnosed cases. This is from the blood spot. It's not counting hearing or critical congenital heart disease. Okay, so there is clinical care coordination that's very much part of the system, and it's to make sure that anybody who has an abnormal screen gets walked through the process. So the CCC staff will notify medical providers of results and provide recommendations for follow-up testing and other intervention. So as I said, over 1,000 babies are diagnosed, so there's all of these babies are screening. The staff do work 6 days a week, so including Saturdays, so that if you get a call, listen to them. Okay, so let's go into hearing. Hearing is a mandated test for Texas, and there is only there, so you have to opt out, and there are refusal forms at the state lab. We want to make sure that babies with hearing loss are identified as early as possible. It's one of the more common conditions affecting about 1 in 200 to 400 babies. And the idea is to make sure they get appropriate interventions. Babies who are identified early have normal neurodevelopment. So there's two screenings, the OAE and the ABR. OAE is the otoacoustic emissions. The baby gets a probe in the ear, and then a sound is produced. And what you do is you can reflect on the peripheral auditory system to the cochlear outer cells. So if you have cochlear hearing loss, you may or may not get a positive on this because if there's middle ear fluid or external canal issues, you may not get a good screen. It is the more widespread because it is easier to use. If it's initially abnormal, you do need to repeat it. And so it is automated with algorithms on computers. So it actually can be done by people with not a lot of training. Important thing to remember about OAE is it does not identify auditory neuropathy. Okay, ABR is looking at the auditory brainstem response, and I hope you see this picture, but there's a little probe here and a little probe in the ear, and it records the neural activity in the cochlear, auditory nerve, and brainstem response to auditory stimuli. So it does reflect the status of the eighth nerve, so you can identify auditory neuropathy. Baby has to be asleep, and it is automated. So if they're abnormal in this test, then they do need to go to an audiologist for testing. Places that take care of NICUs they need to have the ABR because NICU babies tend to have more auditory neuropathy. So we had more legislation regarding newborn hearing screening in the 2019 legislative session. Senate Bill SB 1404 says that we now have to have consent to document that any hearing and intervention outcomes can be shared with the state TEDdy program. And then if necessary, that information can be shared with the school for the deaf. And there is a consent form. If you don't have a consent form, you can still do the screen. You can put into the TEDdy system that a screen was done, but you cannot put the results of that. Okay, so one thing that's very important to understand about early childhood hearing loss is that 50% have some kind of genetic abnormality, and most of those are non-syndromic, and they are mostly autosomal recessive. There are genes that have been identified. So kids who have congenital deafness need to have their genetics tested. Another 40% are caused by congenital CMV, and we've already talked about CMV and its issues. PEDI is the state hearing thing. It is a web-based hearing database. It tracks intervention. It also offers certification of newborn hearing screening programs. We do a really good job with screening. Of 98% of newborns are screened. Again, the incidence of hearing loss is 1 to 2 per 1,000. School-age children are more prevalent because there's ongoing hearing loss, much more prevalent in the NICU population, where the ABR is recommended for screening. They do have auditory neuropathy as well as sensory neural hearing loss. But because babies are born so early, frequently following the Joint Commission on Infant Hearing and the TEDdy goals, which is screened by 1 month, diagnosed by 6 months, intervention by diagnosis by 3 months, and intervention by 6 months, is not usually followed. There is data that babies as early as 34 weeks gestation can be screened. So resources for newborn hearing, there's an infanthearing.org as well as, and they do go into what all the states do, and there's babyhearing.org that are good sources of information. Critical congenital heart disease screening came about in the state around 2015 with legislation. Incidence is about 2 per thousand. We screen for hypoxia using pre and postductal SAT strip monitors. Things that are left side outflow obstruction may not be picked up with this because the ductus is still open. There is ongoing research about using perfusion index as opposed to looking at the oxygen saturation. Actually, in about 2022, there was convened of the experts in CCHD screening, as well as other stakeholders and families, to look at whether the algorithm that was suggested a decade earlier was actually what we needed to do with all the updated research that had been done. And so that group recommended a new algorithm, and then also recommended, instead of having 7 core conditions, that all of the congenital heart diseases should be listed as core conditions, and that secondary conditions are other things that can cause hypoxia, such as hemoglobinopathy, hypothermia, infections, lung disease. Whoops, I don't know why that popped up, or other things like that, or anything that can cause hypoxia. And so it took a while, but AAP eventually came on board. And so these are the new recommendations. And what's new is that instead of having a greater than 95 as pass in either the right hand or foot, which is your pre and postductal, you have to have both. And if you are less than 90 in either one, then it is a fail and you need to investigate. And then if it is between that 90 or 95, or if you have a difference of uh, um, greater than 3%, then you retest. Instead of retesting twice, you only retest once. And if you retest once and it's still in that in-between range, it's considered a fail. And the reason is that it was better to go ahead and test those babies to see if they have critical congenital heart defects instead of waiting longer. Okay, so the reporting that Texas had, unlike hearing where there was tracking and so forth, there was no tracking built into the legislation. So what DSHS did was to learn what the confirmed diagnosis was. And so they created a reporting form, and you were supposed to report it. Well, that didn't work very well. So despite what we know from birth defects registry, that we probably have about 700 cases a year, in the 8 years or 7.5 years since we have had tracking, only about 1,300 cases were reporting. So that type of reporting did not work. But because it is an unfunded mandate, what the state did do was make a better form that can be submitted electronically. So there's a new email address, and you can submit it electronically through the email, making it easier, because in the past you had to print out the form, fill out the form, and fax it, which did not work well. Okay, so a lot of information to give you. Can you remember it all? Just remember, every condition that is part of screening has what we call act sheets that you can access. And fact sheets, some of the fact sheets have been retired. People are working on them. If you just know the disease and you put it into your search engine, you can find this information, and the act sheets will tell you what to do. And it does it in language that parents can understand. Very important to have family support. What good is it if you diagnose a condition and people can't take care of their children? So there is a program that the children with special health care needs, all the kids that have metabolic conditions are referred to them. And if you can meet the financial requirements, then you can participate. And so you get your care provided. CF patients are eligible for CSHCN for life. If you don't have Medicaid or CSHS, or CHIP or any insurance at all, the state newborn screening program will provide food, medications, vitamins, testing, and follow-up care at no cost or reduced cost. But you have to be a Texas resident. You have to be less than 350% of federal poverty level, and priorities given to children 2 years and younger. Um, so what's in the future? Whole genome sequencing. The history is we had the CRISPR gene technique. A program has been done to show that genome sequencing can work in newborn screening. We do know that there's gene therapy that has been approved. New York State has done a program that was funded by NICHD. So there are some target genes that may be done. There has been a program called Newborn Screening Translation Research Network that tried to establish a program to kind of look into the possibility of whole genome sequencing. There's a new program called Beacons that has been funded by NIH. So it says pilot 5 to 10 states, but what was announced was about 4 sites that will look into how you can do this program. And I think a picture is worth 1,000 words. So this is Jessica, who said, I will never forget the words. My son tested positive for SMA on his newborn screening without treatment. Most babies do not live past 8 to 18 months. I sat there in disbelief. There are currently 3 treatments. They chose the gene therapy, and basically, they know that there's a lot of unknowns still, but the baby is thriving. And so there's a lot that we still have to learn. But the nice thing is we have conquered a lot of diseases that were very frustrating when we didn't have this therapy. So these are my references, and I'm open for questions. I think I have 4 minutes.
Yes, you got some time, Dr. Gong, but thank you very much for that fantastic and very comprehensive review. Some of those slides definitely elicited some PTSD symptoms from my board's review days. But yes, let's open up for questions. Please feel free to place in the chat or raise your hand. There's a couple there right now. Dr. Williams asks, how is screening handled for home births or those births not at a hospital or birthing center?
Thank you, Dr. Williams, for that question. It is required. So they're supposed to take their child to some place that can do the screening. Okay. It could be their pediatrician, it could be, I mean, that is a part of the law that they have to do that. Now, do they do it because we don't tie to birth certificates? We don't know. And that's one of the things the advisory committee has worked on for decades. Like, we need to know, like, who's not screened. If you think about the numbers of not people that may not have gotten a second screen, which is about 25,000, that's enough to have several conditions that could have been picked up. Oh, thank you, Dr. Donna Beth. Now that Texas is now up to 60 mutations. Thank you. I guess I should have known that.
Dr. Gong, this is Michelle on this. Thank you for a really informative talk and really helpful kind of update. I just, as a person who works in the newborn nursery, it used to be a rare event to have somebody refuse a newborn screen. I remember having to, dig through to find the form and all those things. It has literally been at least once every week that I've been on service for the past 6 or 7 times I've been on service. So it is increasingly problematic. So I just caution pediatricians to be explicit in their query of patients who are coming to their office and not make assumptions that a newborn screen has been done, especially if there's any other sort of standard of care discussions that are, parents are preferring not to do certain things. It is increasingly prevalent despite a tremendous amount of education and time spent, trying to provide that insight to families. So just it's an increasing challenge, which is a little scary because Texas does do a wonderful job of offering so much potential, care in identifying those diseases early. So, but thank you for continuing to fight the fight at the state level.
Michelle, have you shown them the video before to,
Yeah,
and they
I
still
will.
say no? Because that's a
Yeah, and
great
I will
video.
say, I think the efforts in the population I'm talking about is really a
Yeah,
population that probably has to be hit harder up front, way up front in the
yeah.
OB part of their care, um, because by the time they reach us, several of their birth plan goals have not been met because they never intended to be in the hospital, and so we're fighting an uphill battle, and so a lot of times, you know, we're trying really hard to make sure they get their vitamin K and you know, minimal things. I've had babies end up coming in after 75 hours of labor at home who want to leave at 6 hours of life, you know. So it is increasingly, you know, you don't think about it, but it is a little bit of the wild wild west in those settings.
You should talk to Tiffany McKee Garrett because she's on the newborn screening committee and she does newborn for Texas Children's.
Hmm.
And she's been complaining about these things for quite a long time because they've had that population quite a
Yeah,
bit. Yeah,
but thank you.
you're welcome. Jane, Dr. Lynch.
Hey, that was great. I have a question. Do you know what's screened in Mexico? Do we have an easy list to look at to know what gets missed?
There are a lot of countries that don't do any newborn screening, and there was a time when I was working with some people that were like going to countries to say that you need to do screening, and they were just trying to do basic screening. So I have no idea what the law is in Mexico. The assumption would be that they didn't get any screening, and you
Yeah,
do know that if you get a baby, that used to be you could screen up to a year. You could just go ahead and send the screening when you see them. If um, I think they're going to relax it even more for like adopted babies and stuff like that. So you can send in the screen.
that's great. I think it's maybe a private pay thing in some areas, but
Hmm.
we always worry when kids have been born in Mexico for hypothyroid, for adrenal, for metabolic. You don't have that safety net.
No, you don't. Um, yeah, unfortunately, that is difficult to do. But if you get a baby that someone has that move, you can send that screen in.
Okay, that's
Okay.
great to know. I mean, I think we've done it, but and where do you get the card? You just what would be the easiest way to make it happen?
The hospital has them. I mean, if
Okay.
you send them to the lab, they have them.
Oh, okay.
Um,
That's
the
easy.
in private practice, you have to kind of buy those kits, or you can say you have a Medicaid patient and then and get some. But um, it's very nice. I mean, the hospital. I see people going to the lab to get them drawn for their second screen, so they have the kits. You just have to provide all the information for it.
Perfect.
Okay.
Thanks.
And chat, the best way is a website. Okay. And so certain people have access to that website. If you're a provider, you can get access, but for us, like we have people that work in the NICU that have access, so they get the information. They can go in and get. Now the hospital, our hospital, actually has it where we have a direct connection to the lab. So when we send a specimen from our hospital, when the results come back, it will show up in the medical record, which is amazing. You don't have to go tracking it down.
All right, well, if there aren't any other questions, thank you again, Dr. Gong, for that fantastic presentation. Thank you, everyone, for attending Grand Rounds today. Please don't forget to complete your post-Grand Rounds survey and provide feedback. That data helps our speakers and also our program as well. So otherwise, have a great day.
Thank you.